My guest today is Dr. Nozer Sheriar, one of India's most respected gynecologists and obstetricians. He's a specialist with high risk pregnancies and pregnancies among women who are slightly older in age. He advises the WHO and he's authored books about women's health and perimenopause. This is part of a series of collaborative conversations we're having with the PD Hinduja Hospital and Medical Research Center. Today, we're going to talk about high risk pregnancy, about pregnancy among women who are older than 35, and about fertility. Take a look. Dr. Sheriar, thank you so much for spending time with me. I've been meaning to have this conversation with you for a very long time, so I'm glad we have time together today.
Thank you, Faye. And thank you for always speaking out on issues of importance. It's very special to us.
Thank you. I want to talk about late motherhood. I find that terminology to be best suited because I remember there was a time when women after the age of 35, when they were pregnant, it was called a geriatric pregnancy, which thankfully the medical fraternity doesn't use anymore. I remember I had my son at 40 and it was called a precious pregnancy, which again is a nicer way to call it. But to begin with, has science and medical ability changed the zone, the age zone, where it, where it continues to be safe and comfortable for women to have children?
Yeah.
What are you noticing?
So, Faye, first of all, the term geriatric should have never been used.
Yes.
I would never use it because even if you go by common sense, geriatric is 65 plus.
Yes.
The modern terminology, which is a much nicer terminology, is to say anyone who's having a baby after 35 as having an advanced maternal age,
Yes.
AMA. And after 45, they call it a very advanced maternal age, AMA. So that's a great terminology to have. Precious is fine, but I think every pregnancy is precious. So I've never understood why an IVF pregnancy is called precious or pregnancy at this age is called precious. You're demeaning these. So every pregnancy is precious. Yes, we've seen a complete shift. Today, in my practice, urban practice, metro city, a large percentage of my patients come after the age of 35, many of them to have their first, and some of them to have their second, or sometimes even the third child. 40 doesn't surprise me at all. In fact, today, to date, I probably have 200 pregnancies and counting in women over 40s. We published 50 in the Indian Journal many years ago, then we moved to 100. Today it's 200 and adding to it every week. Yes, things change. So we have to also change our attitudes. And I'm talking about attitudes in the profession, not just everyone else's attitudes. You'll always look at a woman with surprise who's having a pregnancy at this time. I mean, I have 45 and 47 years old quite often. The medical profession actually does have the tools today to help these women have babies when they want to have babies, not when they were supposed to have babies, which is where I think society and the medical profession should be held to a higher standard because we talk about choice in everything. And how about choice here as well? Yes, does it get difficult? In many ways, it does. But that's a decision for her to make and not for us to make. We just have to make it happen when she decides to want it to happen.
So I remember earlier in my life when I went to a doctor who told me that this is the range. You should be having your babies between 18, 20 and 35 because after that it gets more difficult and the number of eggs and the fertility starts to wane. So this is the range. According to you now, given everything you know, is there a new range?
So there's fertility.
Yes.
And there's no doubt that fertility is probably at its highest in the late 20s.
Hmm.
And then there's a gradual reduction to maybe 35. And then there's a further reduction after that. So if you're talking about fertility and conception, well, if you went back to nature and tradition, and if you went back in human history, women who are having babies in their late teens and continue to have babies all their lives. We don't do that anymore.
Yeah.
When it gets later, there is a possibility of requiring some form of medical assistance, which is okay. We've got a lot of different ways of doing it. And in fact, it's interesting because we really have this conversation in the medical profession where people are saying, women shouldn't wait for too long. They should have the babies before it gets difficult. And my argument back is no, women should have babies when they want to have babies and not when they have to have babies, because when a woman has a baby, when she's not ready for it, who sacrifices? Only her.
Only her.
She gives up education, she gives up profession. And why should she have to do that? So she has to have a choice. She has to wait for the right person to plan her baby with, or not always. She can also do it on her own. And of course, at the same time, she is the one who says, I'm now ready for it.
Yeah.
My message to women is sometimes things don't have to happen sequentially.
What does that mean?
Things can happen in parallel.
Okay.
So a lot of times I feel, and this is with my patients, men and women, they've set a certain goal. My first challenging question when a couple comes to me to talk about planning a pregnancy is, when do you want the child? And they get a little taken aback. And I try and pin them. When? Tell me whenever it is. 2027, 2028, 29, 30, you tell me when. And then we work our way backwards to say, how can we make that possible? So sometimes when a woman is in a position where she says, I could have it, but maybe not just as yet, and she could work things out, how about making both things work out? But again, on her terms and on her time.
That's fascinating, because for me as an older mum, and it's interesting. So my son is now in school, and among his classmates, there is a batch of women in their 40s, which means that we all had children at the same age group. I find that I'm better able to control my situation.
Yes.
I'm further along in my career, which
Yes.
means I'm able to navigate the
Yes.
changes better. I'm in a more powerful position.
Yes.
I'm able to afford better help
Of course.
and better support and
Of course.
decision making. I don't allow family members or extended family members, the Buadi G's and the Tauji's, to like bully me because I know what I want. But I found recovery to be harder
Sure.
as an older woman. If I were to ask you what the risks are, and I'll separate it for the mum and the baby separately. For a mum after the age of 35 and then after the age of 40, what are the risks of a later, an advanced maternal age pregnancy?
So the first thing is getting started.
Yes.
So there definitely is this time when maybe you just don't hang on, trying naturally forever, and you set yourself a certain time frame. Maybe in a younger woman, 8 or 10 years younger, we could even say, you know what, 1 year, your cycles are fine, your timing is okay. Infertility is defined as 1 year of trying naturally and not conceiving. And as I remind people, in any given cycle, a younger woman has a 12 to 15% chance of getting pregnant. So be patient.
Right.
And this is, of course, if you time everything perfectly, which you
Yes.
may not always. And then over time, in 6 months, 50% will be pregnant. So we say, give yourself time. When you are over the age of 35, we have tests that can determine your fertility status.
Yes.
So we need to know where you are along your fertility path. And there are some women who will be extremely fertile even in their early 40s. And there are other women who won't be that fertile in their early or mid 30s. Once you know this, you can then temper your advice to them and say, okay, you've come to me, you're planning a pregnancy. Now let's do the timing thing for the next 4 to 6 months. I always say the maximum pregnancies, if you've done things right, happen in the first 4 months. You will have pregnancies after that, but then your monthly success starts going down. And at that point in time, a doctor can step in with minimal assistance, helping you time your fertility, identifying ovulation, giving you just the bare minimum medications, and then working things out. Let's not forget that you also have a man in the equation.
Yes.
Who's probably around the same age. older or sometimes younger. And it also depends on his fertility. So I would never ever do anything for a patient of mine unless the husband's also tested and we know that both of them are kind of okay to try. So that's the fertility part. When they come later today, fertility has new treatments. Assisted reproduction has now been around for a very long time, many decades.
Yes.
And for many of these women, going for assisted reproduction or an IVF may be the way to go. So I would quickly move from 4 months. Now, this is a woman in her late 30s of trying naturally. Many of them will conceive to maybe a simple procedure like an intrauterine insemination to an assisted reproduction. I'll say, let's try and do this in the next 1 year.
Right.
And in 1 year, about 75-80% should have their pregnancy. What happens to the woman who is the very advanced age and who wants to still have a pregnancy and she's not able to do it with her own eggs or her oocytes? Today, technology allows you for donor oocytes, and a woman who's menopausal today can still aspire to and successfully become a mother using donor oocytes, which is basically a younger woman's egg. She has the pregnancy, she carries the baby, she gives birth to it, so she has all that in her life as well. So that's the fertility part. Now she's pregnant. We'll talk about the fetal issues later, where there are certain things that we need to keep in mind with an older pregnancy. But as far as she is concerned, there is no doubt that when it comes to obstetrics, there will be a slightly higher miscarriage risk,
Okay.
which you have to factor in. Any pregnancy has a 10% miscarriage risk. A woman conceives, she has that risk. At this age, probably after 35, I'd say the risk goes to about maybe 15 to 20%.
Okay.
When you tell women this, they are better prepared for what happens to them. And when they are in their 40s and mid 40s, this could go to as high as 30% plus. Once they get through the first trimester, in later pregnancy, they have a higher incidence of medical issues, particularly hypertension in pregnancy, something we call as preeclampsia. And some of them might already come into the
Yes.
pregnancy hypertensive, or gestational diabetes. Diabetes in pregnancy, some of them may come to the pregnancy with the diabetes. So this is something that we need to keep in mind, that when you do plan a pregnancy, you have to make sure that this woman is in great shape to do it or get her in great shape to do it. We are dealing a lot with women being overweight nowadays, and the work on that has to start before pregnancy, continue through pregnancy. And by doing these things, we can make the pregnancy safer. Where modern medicine has probably stepped up is, let's face it, all obstetric practice has become safer
Yes.
than what it was 30 years ago. Women still die of pregnancy. That's a very bitter reality. But we have managed to bring down those mortality rates dramatically. We should now talk about morbidity. And there is morbidity in some of these patients, which we've got to try and minimize by doing all these things. But with the technology we have, with the testing we have prenatally, with
What is the difference between mortality and morbidity in this
mortality
context?
is when the
Yes.
you lose a woman in
Yes.
pregnancy, and morbidity is when you have major illnesses in pregnancy. And sometimes this morbidity can be severe, where you need all the stuff that you have medically to make sure that this woman stays safe and pulls through it. So this is more than if she was 25 or 30. But
Yes.
like I said, thankfully today obstetrics and obstetric medicine has developed to a point where we are geared to be looking after this. I mean, I can give you stories and stories. We had a dramatic emergency at one of the hospitals I work at, Hinduja, just 1.5 or 2 months ago, where in any normal situation many years ago, that patient may not have survived, but she did. So that's where modern medicine probably has developed, and we are better positioned to look after all women, but particularly these women.
I remember when I was getting my regular ultrasounds, there were family members who said, why are they testing
many
so
others.
much? There are too many ultrasounds. Doesn't it harm the baby? Are they doing it only to just rake up the bills? So there's a lot of that noise.
Yes.
And as an expectant mother, you start to get, everything makes you nervous
Yes.
because you're just on that
Yes.
slightly anxious side. But what is your advice to expectant
So we've
mothers?
been
Too early
doing
to.
ultrasound since the mid 60s. And
Yes.
as of now, we know that nothing can be safer than an ultrasound. When we do these tests, obviously there is always the girl's family and mother saying, but I didn't have ultrasounds. I had one ultrasound and I tell them, you know, we've seen the before and we've seen the after. I mean, I'm taking you back to 1985, where sometimes we delivered twins without knowing she
Without
carried
knowing.
twins. One baby is born and wait, something else is happening. We delivered babies with some of the worst birth defects without knowing they were there. So today you can look into the womb, get to see the baby, and some of it is just mandatory. I call them landmark ultrasounds. Additional ultrasounds are done when they are needed and required. And trust me, sometimes it's even patient driven. You know, patients just feel so good having
Yeah.
seen their baby. And
Yeah.
today, with three-dimensional and 4D ultrasounds, getting photographs of the baby, why shouldn't she have?
Yeah.
Cost obviously is a factor, but I must say today ultrasound is probably available everywhere in this country at all the different ways it can be done. And when it comes to testing, and I've always believed the tests I do for my private patients, I also do for my OPD patients at, say, a Holy Family Hospital. And I've always said, let patients decide whether they want to and whether they can afford it. And the the costs of missing something are far greater than the costs of testing something. So you have to do what is scientific.
Yeah.
You have to do what is evidence based. That's extremely important. I mean, it'd be foolish for us to be doing an ultrasound every few weeks. But like I said, landmark ultrasounds have to be done and landmark tests have to be done, with selected patients getting more. I have to deal with families all the time and we have to carry them along with us.
Yes.
We have to
Yes.
also tell
Because
them.
it tends to be a group project.
Thankfully, today, now for a few decades, it's become a lot of partnership between the couple.
Yes.
And what I didn't see when I started practice, I'm seeing men with their wives all the time. When it used to be, women used to come with women. So that's changed. Yes, I do sometimes have 6 or 7 people in the room, both sets of parents, and always some family member who knows a lot and who's there to ask questions, which is absolutely fine. But we've got to carry them along. And the way you carry them along is to make them understand times have changed.
Yes.
Technology has changed. You've got great stuff available. And why not use it if it's available? And sometimes I give them like silly analogies, like I get this, should she take an why should she take an epidural and it's not natural? And I say, well, flying in a metal tube tens
Yeah.
of thousands of feet above the air is not
It's not
natural, and you
natural.
still do it, right? That's technology. How about you walk to Delhi instead of flying to Delhi? That's how people did it in the past. We don't do it that way anymore.
Yeah. That was going to bring me to my next question, which is, as you see women further advanced in their age having babies, does it almost always lead to a C-section because that's the safest way to get that baby out? Or does that not matter? Is the age a factor when you're making that
So
decision?
I wouldn't go as so far as to say it does not matter, but I have always believed that a woman, irrespective of her age, does not need a C-section unless a medical condition demands it. Some of them may request a C-section, and some women may request a C-section, and most of the times it's the fear of pain, and you tell them about painless labor and epidural analgesia, and they will change their minds. So I will always fight for a woman's choice and request. But believe me, most women do not want a C-section. And personally, I deliver my very advanced maternal ages vaginally all the time. And I would think, obviously, the incidence of C-sections would be higher than other women, but it doesn't have to be that high. And if she's in great shape, she is in great health, she's looked after herself well, she's worked out and prepared for this day all her life and throughout pregnancy, there's absolutely no reason why she can't have a vaginal birth. Saying a vaginal birth is more dangerous is not true. Saying a cesarean is safer is also not true. It is a major surgery, and today there are certain issues related to C-section, which we didn't see in the past, which we are seeing now.
Like
Certain complications. Future pregnancies having adherent placenta and stuff. So That's something that's happening. So I think that's to be done on an individual case by case basis. But just because she's 35 plus,
Hmm.
just because she's 40 plus, just because she's had an IVF is absolutely no indication for a routine C-section. We do a lot of vaginal births for these women.
So I know that after the baby is born, there's a 4-week follow up with the doctor, and then you manage your recovery at home. But is it more difficult for women who are older to recover from pregnancies?
Yeah. So first of all, generally the first follow-up is usually in about 2 weeks.
Right.
Uh, a very important follow-up because that's when you see how she's recovering physically.
Mm.
That's when if she has an abdominal scar of C-section or a vaginal repair of a tear or an episiotomy, you check it out. It's very important for her to be motivated to exercise. And I believe that a C-section starts exercising at the same time as a normal delivery within 2 weeks. She has to. You motivate her to break tradition and get out of the house and feel good about herself. Every patient, I believe, should get a small scale which helps objectively assess what's happening to her emotionally because patients in the past came and told me nobody ever told us about blues and depression and we struggled with it for months, so we need to be better prepared. So this is for all women. Now
Yes.
for this particular woman, yes, it is true that with age your body does take a longer time to recover from what you've gone through. If you ran a marathon at 30 and you ran a marathon at 40, you'll take a few more days to for those muscles and joints and everything to recover. But you will recover. And this is where prepping for it is a
Yes.
big part of it. I've always believed and told women that, at the end of pregnancy, you are going to run a marathon. Now, you don't run the Mumbai marathon by waking up one morning and say, I think I'll run today. You
Yes.
prepare for it months in advance. And if she's prepared for it, if she's done a weight right, if she has done reasonable strength training, built up her stamina, she will do it great and she will recover very well. I did tell you about a patient of mine who had babies almost 10 years apart. And the second time around, she was late 30, almost 40.
Mm.
And she actually said this, Doc, my recovery when I was in my late 20s was almost easy. And now it is a big effort. And she did it. She's amazing. She's done great. She came out of it. She literally pulled herself out of it. But she actually said this, that when you compare the two, it will, so be it.
Yeah. Doc, you talked about building systems to keep women safe when they have children later in life. Is there a risk to babies when the mother is older?
Yeah.
And how do you mitigate that
Yeah.
risk?
So this is one of the biggest concerns a woman will voice.
Yes.
Will my child be normal? I've heard that there are more genetic problems. I've heard there are more structural problems. And what can I do about it? So, firstly, there is no doubt that with age, the incidence of genetic problems does go up. Now, I'll take the one condition which is supposed to be the commonest. It's called trisomy 21, which was which was called the Down syndrome, which was the commonest cause of genetic cause of mental retardation. So this is the concern women have. A 25-year-old woman has a 1 in 2,500 risk. At 35, it becomes 1 in 350. At 40, it becomes 1 in 100. And at 44, 45, it becomes 1 in 30. So you can see it goes from 1 in 2,500 to 1 in 30. Because I'm an optimist, and even in 1 in 30, I like to say, oh, 29 normal to 1 abnormal. Because we've recognized this, these women are always under the microscope when it comes to identifying defects. So I must say, today we do it for all women because a younger woman can have this as well. So at the 12-week mark, they have tests, a sonography, a genetic test, the NIPT we discussed, and these things can actually identify the abnormal pregnancy. And the first thing I tell a woman when I'm counseling her, even before she conceives at this age, is we're going to work for perfection and normalcy. And if there's something abnormal, that's not the time to get emotional. We're going to let it go.
Mm.
And we can actually do that. there's a slightly higher incidence of structural defects, not genetic. We usually pick those up at 18 weeks. And thankfully, we have a law in our country which allows us to terminate such pregnancies as well. So while the risk is more, this risk can completely be mitigated by identification of these risks and by taking whatever medical action we need to protect the woman. The one other thing that comes up constantly is autism.
Mm.
Unfortunately, we don't really have any tests for autism at the moment. There may be a slight, we always call this an association rather than a cause. So this is a concern mothers always have, and we tell them, well, your risk is probably the same or marginally more than a younger woman. And I don't think we should really be concerned about it because you should go for what you want. And remember, we are talking about this when the woman is using her own eggs. If she is a woman in her mid 40s with the donor eggs, her risk becomes the risk of the
Of
donor's
the
age and
donor.
no, not
Yes.
her age. So that actually is also a modicum of safety. Uh, Another very important part of this is again when you educate the woman and the baby is born, we actually tell women that these are the milestones you expect to see. You are the early warning system. Do not be in denial. Mothers and families often are. Pick up things early, and there's enough help we can give for a child which may be lagging behind on milestones to pull up the child. So, we today, the first thing is to understand that the risk exists. The second is to understand the risk is identifiable and can be picked up. And the third is we can medically take care of the fact that this pregnancy, which is not normal, does not have to go ahead.
So actually, I meant to ask you this. There used to be a time when babies were delivered in what were called maternity homes, or a maternity hospital, which was a standalone
Yeah.
unit. How important is it right now, especially when we're talking about women who are a little further on in age, to look for a hospital that can not only deliver your baby, but also care for that baby immediately in a NICU with all of those facilities as well?
So I cannot stress how much maternity homes have done for our healthcare system. Probably 70% of healthcare was delivered by small nursing homes. Unfortunately, the modern system is kind of literally squeezing them out.
Right.
And the second thing is it's great when all goes well. But today, when we are dealing with more and more challenging, high risk, and complicated pregnancies, I would prefer to be in an institution which is a multi specialty institution. I told you about that one patient.
Yes.
Now, this was one of the hospitals I'm at, Hinduja Hospital. That patient wouldn't be alive today if we weren't in that hospital. Here we were in the theater, the patient flatlined on the table. We resuscitated her. We had the team immediately come in code blue. We took her to the ICU. We had intensivist, physician, cardiologist, nephrologist all there. We had the baby being taken care of. That would not have happened if we had not been. But if you are a low risk patient who basically is otherwise having a completely normal pregnancy, by all means, go to that neighborhood friendly nursing home after making sure you have the facilities, you have an experienced doctor, you've got round the clock assistance. What do you do when I have a problem? Where will I be shifted? Do you have basic stuff like I cannot dream of practicing obstetrics without epidural analgesia?
Mm.
Do you have an anesthetist? Please, you'll be more comfortable there. But the moment there is a risk factor, you have to find an institution which gives you everything under one roof. And that for me is something that today, with my practice being more high risk, I'd rather practice it. I'm not saying in my time I did deliver babies in nursing homes and I love doing it, that the coziness,
Mm.
the doctor there, the nurses there, the patient made to feel special. So I think there's a place for both.
I do want to talk to you about younger women now, women who are in their 20s, who want to give themselves the option of a later pregnancy because they want those choices. What should they be doing now at 25 to keep those options open at 40?
Okay. So the first, I usually have this, see, we all have dates in our minds. So I usually have this conversation with my patients at around age 32.
Right.
Okay. Talking to a 27, this 27-year-old still has years to go and a lot can happen, though you can talk to them about it as well. At 32, I tell them that, you have options and you're not sure where you're going to be in life. You're not even sure who you're going to be with, when you will plan the pregnancy. And at this point in time, you have the option of considering freezing your eggs, freezing your oocytes, which is basically an IVF procedure, but half an IVF procedure. You've taken the eggs, frozen them, and then you stop
Yes.
and continue at a later date whenever she's ready. Once this is done, firstly, because she's young, she'll probably give a great response. She can do the same thing 5 years later, but she'll give fewer oocytes, so she'll have to do it more than once. Secondly, if she's done it at this time, remember she's frozen eggs which are 32 years old
Hmm.
genetically and age-wise. So even if she's using them when she's 40, she's still using 32-year-old eggs. So that's an advantage. And women can be guided by additional testing. There's a test called AMH, and sometimes we do have women at this age having a lower AMH who need to be told, you need to think about it now. Or a woman might have a great AMH and she's, I'll take a year or two more. I always give them a second option. And the second option is to tell them that, listen, this is where you are. You can freeze your oocytes. But suppose you did decide to not freeze your oocytes for whatever reason. I don't want medications. I don't want the injections. I don't want to do the procedure, and it costs. Then in that particular situation, you're probably going to be conceiving on your own for many, many years. So you don't need to worry about it. And if you can't, and if you suddenly wake up when you're 42 and say, I didn't freeze my oocytes, you still have the option of a donor egg or a donor oocyte. Believe it or not, 50% of my patients say we'll do the freezing, and 50% say, Doc, that makes great sense. I would even adopt a child if I had to.
Yeah.
And this is like doing quarter in adoption because 50% of genetics, but you carry the pregnancy. So that the important thing is once she knows and once she's given choices and options, she makes her own decisions, and it's usually the right decision.
What can women do through their 30s to preserve their fertility for as long as possible? You talked about fitness and you talked about
Yes.
lifestyle.
Yes. So first of all, I today, let's face it, we are seeing medical issues. The first thing when a patient comes to me, I say, what have you come to me for? And she says, Doc, I've come to you for PCOS. I said, no, you haven't come to me for PCOS. That's a diagnosis. What have you come to me for? And she may have come to me for nothing. Someone just told her she's got PCOS on an ultrasound. So, but if she's someone who has a weight issue, she can be guided. If she's someone who has a medical issue, so a healthy lifestyle, a healthy diet definitely helps keep you going. Interestingly, I believe that we have underutilized contraception for non-contraceptive benefits.
Okay.
So people, the moment you talk about the birth control pill, people will say, my God, it causes cancer. Well, firstly, it doesn't. But interestingly, today we know that the birth control pill or the hormonal contraception actually reduces your chances of ovarian cysts. Endometriosis is a big problem we are dealing with today. Reduces endometriosis, reduces chocolate cysts, and even reduces ovarian cancer. I wish we put this message out there. People would be more amenable to using a superior method of contraception rather than taking risks with not effective methods and then having unintended pregnancies, which of course we'll deal with. But why should we have to do it? So there are ways and means today of actually protecting her. And I sometimes tell my patients, if I had 100 patients on the pill and 100 patients not, at the end of it, the ones who are on the pill will probably do better with fertility than the ones who are not.
So that's theory that if you're on the pill and then you go off it, there is a surge of fertility and the chances of pregnancy are higher. Is
To a
that true?
small extent.
To a small
To a
extent.
small extent. Basically, once you're off the pill, you're off the pill. The modern pills, so the olden pills had a problem. They were higher doses, they were different preparations. And there sometimes you had something called as a post-pill amenorrhea where they took months to get going. We also have other methods like injectables, which do take some time to recover from. But with the modern pill, she gets off the pill and within a month or two, she gets back to her fertility. Yes, what does happen to her is she basically goes back to what she used to be. So someone will say, but doc, now my periods have gotten disturbed. And I remind them, your periods were always disturbed. And while you were on the pill, your periods were great, but that were the periods of the pill and not your periods. So, so yes, so it is true to a small. In fact, interestingly, if you went back in history, that was the purpose for which the pills were invented. There were these people, Rock and Pincus, and Rock was a gynecologist who was a fertility specialist. And his idea was, let me have a method where I can suppress and then take away and have better ovulation. But then they realized that it was far more effective for birth control than for fertility treatment.
But there are a lot of concerns about the birth control pill having side effects, weight gain, irritability, all of the issues we have around hormones.
So again, extremely individualized. And the amazing thing today is we had so many choices. We are on the fourth generation. And we are still carrying the baggage from the second generation to the fourth generation. The fourth generation pill is weight neutral. In fact, it reduces bloating and fluid retention. So you might actually lose a teeny weeny bit. The second thing is it's actually one of the only methods approved by the US FDA for PMS and PMDD. So if you're talking about that happening before the periods, we sometimes use the pill to treat it. But having said that, there will be situations in which we don't use the pill. And I've always told my patients, as I said, pills are extremely safe. Some women are dangerous. So I have to find those and not give it to them. A heavy smoker, a person who has heart issues, a person with a history of thrombosis or a risk of thrombosis, someone who's a very high BMI, someone who's leading a very sedentary life. I would give her the pill. I've got other alternatives to give her. But for most women, it's been wonderful.
I mean, you did mention smoking. For women who hope to maintain their fertility for as long as possible, how detrimental is smoking and alcohol consumption?
Smoking, definitely yes. Social drinking, probably no.
Okay.
Smoking, definitely yes. And I'm totally a liberal who believes people should do what they want to do within reasonable limits. But if there's one thing which does harm with no benefits, it's probably smoking. And here I must also add, and suddenly I find a lot of my patients say, Doc, we don't smoke, we vape. And believe me, my friends, the endocrinologists have told me that today they are seeing more hormonal issues and problems in men and women who vape than who smoke. So if you're really looking to maintain your health and your fertility, it's best to try and curb all these things which can do damage to you in the long run.
How important is nutrition for women who are planning a pregnancy, even if it's not immediate? Supplements, nutrition, you did talk about weight a couple of times, stress management. We live stressful lives.
Nutrition, I cannot stress enough the importance of nutrition. Again, so big part of my personal practice is my dietitians. It's like almost mandatory. You don't have a choice. You're pregnant, you have to work with my dietitian. And I've always believed that if you can get good stuff from your diet, that's where you should be getting stuff from.
Rather than taking
So
the
don't go on
supplements.
adding stuff and scoops of this and scoops of that. It's not necessary. So that should be bedrock. That starts earlier. That obviously helps you be healthier. And I'm not, see, people think diet is all about losing weight. No, it's a lot more than that. Diet is just keeping yourself in great shape. Then comes physical activity and exercise. Important, very, very important again. And particularly for a woman who's planning something in later life and you want to run that marathon when you're 42, you damn well be in good shape and look after yourself. Supplements definitely have a role. But as the word suggests, supplements are to supplement and not to replace.
Yes.
You can't replace a poor diet with supplements. Now, how do you decide a woman needs supplements? I believe in testing. And today I'm seeing two extremes. I'm seeing tremendous deficiencies of vitamins. And sometimes I'm seeing vitamins at almost toxic levels.
Oh.
Because people are overdoing supplements. They're suddenly taking a B12 from 4 different preparations. They're suddenly getting shots of vitamin D, and before you realize it, you've gone sky high. So take supplements that you need, and well, you have to work with someone who knows and do your own
So
research.
I find that there are different points of view on this. So there are some doctors who have spoken to me on the show who have said, you know, take your, the Centrum or the Supradine, the one that has everything in it, one a day. And there's another school of thought that says test and supplement only for deficiencies and then stop when the deficiency has been fulfilled. Do you believe in the latter?
No, I believe in both. I'm somewhere in between.
Okay.
So once you've done with the deficiency, why are you waiting for it to get deficient again?
Again. Okay.
So there has to be a maintenance dose. Let's give you the simple example of a vitamin D. Sunny country, nobody goes out in the sun.
Yes.
Tremendous vitamin D deficiency. So you supplement vitamin D. And I bring her to a decent level. She's not going to suddenly start going out in the sun, right? So what am I waiting for? But maybe I'll start off with once a week and then say, now you maintain it at once a month. B12. It depends upon where you are. It depends upon your basic diet. Are you vegetarian? Are you non-vegetarian? Are you getting enough from your diet? You aren't. You're keeping a borderline B12. How about we supplement a basic level of B12, which is like the multivitamin preparation that you mentioned and many others, and find which one works for you. So, so no, there is no one medication for everyone. It will not do justice to you because the ones who are really deficient won't be served, and the ones who don't need it really don't need it. All you do is you'll probably have very expensive urine because that's where the vitamin is all going to go out from. Individualize. Each woman has to be treated differently, and do not shy away from testing so you know exactly what you're dealing with.
So don't prescribe the supplements. Actually, go to a doctor, get it tested,
That
figure
would
out.
be ideal.
Yes.
But after that, he's not going to call you, or she's not going to call you every month to
Yeah.
fill that prescription. That wouldn't be. So he's probably going to give you the guidance, and you should do your, every woman, particularly any woman after the age of 40 for sure, but even after 35, should be doing at least one routine visit with their chosen doctor every year. And my message to my couples, and usually this is targeted at the partner, if there is a partner, is every year after she celebrates her birthday, you're going to take her to a doctor and you're going to make sure that she looks after herself, because women don't look after themselves. They look after everyone around them, but they never, ever, ever step up when they need to be doing things for themselves.
I'm so glad you said that because I was reading a book that said med hospitalization and care for women was usually geared to just getting her back on her feet as quickly as possible
Yeah.
so she can start serving all of the people she looks after. And women tend to not go to the doctor until they've reached a point of collapse
Yes.
and they tend to put it off.
And very often, when they do come, and there's enough evidence to show that their symptoms aren't given the importance that the same symptom would be given in a man. And studies have shown that when a woman walks into an ER, she's 4 times less likely to be diagnosed for a heart condition than a man who came in with the same symptoms. So, women, it's up to you. You take yourself seriously. A friend of mine gave me a beautiful analogy and said, when there's on a plane, when there's turbulence, you put on your oxygen mask first. And I always say women never put on their oxygen masks. They are too busy putting masks on for other people around them. And it just doesn't work that way. Even if you want to do that, you first have to look after yourself.
That's beautiful. Thank you for saying that. I do want to talk to you a little bit, if we have the time, outside of the age group that we've been focusing on up till now. There is a concern that young girls are getting their periods earlier because there's more hormones in the milk, in the food. We live in a different world today than we did 20 years ago. How do we look after our baby girls better?
So, 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 you know, demography changes things.
Yes.
And particularly, say, our country generally follows the West,
Mm.
but we always lag behind by a few years. But then we catch up, and urban India catches up sooner than rural India. So, as girls with nutrition and health become healthier, the age of menarche has come earlier. The average age still remains at 12 and a half years, maybe 13. But today we see young girls as early as 10 and a half and 11 reaching menarche, which technically is not considered abnormal.
Okay.
Before 10 is considered abnormal. After 10, it's a little early, but not that early. So we are seeing that. Now, why are we seeing that? One, it's the basic health of a population. As it moves up,
Right.
menarche will come earlier and menopause will go later. So even when it comes to menopause, we are at around a 47, 40,
Yes.
45 to 47 age. The West has now moved up to maybe 48, 50, and we'll probably follow them in some time. But then there's a lot of other stuff happening in our lives, and you did mention it, and we don't even know how much impact it really plays because we haven't really looked at these things closely. What is going into the milk? What is being fed to the cattle and what comes into our dairy? And, you know, commerce will push people to do things to improve their production, but that may not be the best of things for us. So it's something we need to be aware of. The bigger problem I believe the world faces today is the byproducts of the plastics industry.
Yes.
Endocrine disruptors are a group of compounds which mimic estrogen in the human body. A lot of endocrine disruptors come from plastics and come from plastics in the environment. And we are seeing stuff which we wouldn't have seen in men and in women because of the changes that has happened. And I'm sure this is going to affect the developing child, whether it's a girl or a boy, as they go into adolescence. Interestingly, when it comes to male infertility within the last 2 decades, we've seen a dramatic increase in low sperm counts. In fact, the WHO had a cutoff of 60 million when I was a student. Today, they've taken the cutoff down to 20 million because if they kept 60 million, almost all men would fail. So instead of improving the world, we said, let's bring down the cutoff. And that's because what's out there. The same thing happens to certain conditions in women, which we shouldn't be seeing today, but we still are. And that's because, so first of all, educate yourself, look at your lives, look at your kitchens, look at what you're using in your day to day, and let's do whatever we can to make things safe.
Would a good start be to remove all plastic bottles?
Plastic bottles for sure. I
Okay.
mean, I just think that we shouldn't be having plastic bottles in our refrigerators in our kitchen. Now, the problem is when you go out,
Yes.
there will be
I do believe
plastic
COVID
bottles.
set us back a great deal because when we went into COVID, there was this clear move to stop using one-time use, single-use plastic.
Yeah.
And then COVID sort of wrapped the whole world in plastic because everybody felt safer.
Yeah.
And we've just gone back,
Yeah.
in
Yeah.
behavior.
But just as
I
we've
find.
forgotten all the good things that COVID taught us, maybe we need to start forgetting this as well. So during COVID, when I'd see patients, I wasn't seeing the kind of coughs and colds and viral infections because
Yes.
people were being so safe. They were sanitizing and suddenly it's all back.
Yeah.
Those habits were forgotten. Let's forget these habits as well.
If we do have the time, I do want to have a quick conversation about perimenopause and menopause. And I find it very interesting because I talk about it a lot more. Obviously, as a woman with access to research and with information and the ability to speak up about what I'm going through. And at the same time, my mother, who's now in her late 70s, said, I don't even remember this. I don't remember going through this because my life was so hard and we just, So are we being more fussy now?
No, we're being more realistic.
We're being more realistic.
We're being more realistic. And thankfully, we are also coming to a point where women have found that confidence, capacity, resources to speak up.
Yes.
So the book I wrote, nobody was talking about perimenopause when we started writing in 2015, 2016. It took us years to write. My life didn't allow it. And finally, when we had to find a title for the book, it was like menopause. And I said, no, menopause is too restrictive. So we came out with this perimenopause in 2022. And suddenly everybody is talking about perimenopause.
Yes.
I'm so glad they are. There is no doubt that this is a time of major change and transition. There is no doubt that more and more of women half the world's population are going to be living longer and going through perimenopause and what happens after that. So you mentioned mom. Yes, they did it. Yes, in some ways, maybe their physical work, their diets may or may not have been better than what we are today. Maybe their stress levels were less, but maybe they also swept a lot of their symptoms aside and didn't bother about them. So, interestingly, back then there was a study from India which showed that while the West was looking at flushes and emotions, India was looking at the vaginal symptoms. And you know why? Because that is something you couldn't sweep away under the carpet.
Yes.
So only when that happened, they came forward to a doctor and saying, I need help.
If
Whereas
at
those
all.
women would walk in and say,
Yes.
consequences of not addressing it properly are long term consequences. Your heart health and your bone health depends upon how you deal with your perimenopause. So you're not just thinking about now, you're thinking about 10 and 20 and 25 years from now. If you allow yourself osteopenia now and osteoporosis later, the biggest problem of elderly women in the world is a fracture of the femur. So it is something that it's time we gave the importance it deserves. It is something that every woman is going to go through differently.
Yes.
Uh, Many of them may say, I don't have too many issues, but there will be something which may or may not need intervention, but it's important that they be addressed if required. There are some women where it can be incapacitating. I would say for 10%, the symptoms are severe. For 5%, it's like a brings a standstill to their lives.
I read this really interesting thing that data shows that apparently um, osteoporosis, which is the weakening of our bones that happens during perimenopause and menopause, like you said, leads to very often a fracture of the hip.
Yeah.
And research shows that mortality tends to be a lot faster for women after they fractured their hip.
Absolutely.
Which means, putting it simply, it means that we women are more likely to die.
So firstly, you're much more likely to have the osteoporosis and the fractures, which is why you're more likely to have that problem. So all of us put on bone till the age of 40,
Hmm.
and men and women start losing bone from the age of 40.
Oh, yes.
During the perimenopause, bone loss in women is 4 times more than men. And then they again start going along the same kind of path. But by then, they've lost a lot more bone than men would have lost. Because there has been a dramatic change and transition. Men too. And I think at some point in time, few years from now, we're going to start talking about andropause,
Which is
which is the
the
male
menopause for
counterpart.
men.
But it's very gradual.
Yes.
So it's very insidious. In women, it's very sudden.
Right.
It's a very cut-off
It's a
kind of a
cliff.
thing. Click. So what you just mentioned is very interesting because whenever we talk about hormone therapy, and there were studies which created a big scare, and you would have a higher risk of breast cancer and whatever else, what they didn't factor in is the number of deaths and fractures you would prevent if you dealt with it at the right time
Yes.
should also be a part of your calculation when it comes about for the risk benefit ratio. And this is probably one of the big benefits, but not by itself.
Mm.
Lifestyle, exercise, preferably strength training, adequate levels of calcium, vitamin D, and a good diet, not being a smoker, a whole bunch of things would definitely help
So
you.
one of the suggestions, one of the solutions is to lift weights during perimenopause to put the muscle and the bone back. Does that actually
It
work?
has to be functional. I tell women you need cardio because you are going to put on weight.
Right.
Let's face it, perimenopause is going to do it to you. There's a medical reason for that. When ovaries produce less estrogen, the body said, now let me find another source, and the other source is fat tissue.
Hmm.
The second, they have to have some form of flexibility exercise, whether it's yoga or Pilates. Because very soon her joints and her ligaments and her neck and her back, there has to be strength training.
Yeah.
That's the only way you can maintain your bone health. And finally, and most importantly, what most women forget is pelvic health. The pelvic floor needs its own exercises because you got this big muscle holding everything inside you, inside against gravity. And with age, that muscle is going to go loose as well. Men have the same problem, but women have something different. They have an opening called the vagina, and they're very often given birth to it. So their pelvic floor is going to give way. So unless you do all these four things, you're incomplete when it comes to your. So you work it out for yourself. What do you enjoy more? Someone wants to do cardio with Zumba, someone wants to swim, someone wants to walk, run, but make sure you do something 3 times a week and something else 3 times a week and just build it into your life.
Is the HPV vaccine only for teenagers or should everyone take it?
Approval is till the age of 45.
Okay.
I am not sure how effective it is much later. I used to have a notion cutoff of 35. Though when women ask for it, I give it to them even later. Uh, it should be given as early as possible. So I would love to give it to every teenage girl. And if possible, every teenage boy. Where do you think the girls get their HPV from? So Australia does it routinely. For us, it's been approved till the age of 25 for men. So I would even think maybe. So that protection. And today, WHO has said a single dose is enough. You don't even need to give 2 doses. And later on, 2 doses are enough. So we need to do vaccination. We also side by side need to do the HPV pap smears because while the vaccination will protect you against 80%, to be totally sure you also need a pap smear. So it has to be both.
Do you recommend hormone replacement therapy for perimenopause and menopause
Liberally.
Liberally? There
But
were some concerns about it, but
so liberally on a case by case basis.
okay.
When a woman needs hormones, there is nothing like hormone. She's suddenly becoming deficient in something that her body had. We've never thought twice about replacing insulin when a diabetic is deficient in insulin or giving thyroid hormone for a thyroid hormone deficiency. Why this double standard when it comes to perimenopause and menopause? Having said that, this Western mistake that they made in the past of everyone should get a hormone is ridiculous. Nobody should be, nothing should be for everyone. But if you've assessed her symptoms and that has to be done well. Very often, women will come to you with a symptom, but she's really got a whole bunch of hidden symptoms behind it. She may not even want to talk about. So, what I do is usually there is a chart which a woman is given and made to fill 16 symptoms. So it's objective, and based on that, you decide does she only need supplement? Does she only need lifestyle? Could we just manage with an alternative, something called as a phytoestrogen, which are plant-based estrogens? Or should we give her, it's now called menopause hormone therapy. We don't call it HRT anymore because we use estrogens, we use testosterone now for libido and muscle health and stuff. And obviously you have to use progesterone. Is it safe? Extremely safe. Again, there's a lot of responsibility with how it has to be administered. We've got many advances. Today, all the hormones we use are what we call as body identical and the routes of administration through the skin, through the vagina. I've even changed the whole thing in the way it's done. It doesn't have to go through the liver anymore, and it's not.
There are patches, ma'am.
Unfortunately, you don't have patches in India. We can, but we do have transdermal gels and sprays which work as well as patches.
Look, if there was one thing you wished all women knew, what would that be?
Uh, I have always believed that a woman should not put herself as secondary or demean herself. This thing about weaker sex is one of the biggest con jobs that society has perpetrated. She is really the stronger sex. But to do that, she really has to take care of herself. And she's not being selfish when she's doing it. She's not being self centered when she's doing it. In fact, she's quite selfless when she's doing it because a lot depends upon how she is, how she takes care of herself, because that allows her to do everything that she thinks is important to herself. I think this is extremely important. The second thing is, I think women now have to start asking and rather not wait to be given stuff. You know, like we don't, we should be dispensing stuff to women. Women should be out there. And I think perimenopause is one example where women have done it. Today, suddenly it's become a buzzword because women started talking about it. And women started going to their doctors and asking for, can we not do something about it? And women started telling doctors, don't you think the symptom of mine could be because I'm perimenopausal?
Yes.
Because a lot of doctors didn't even connect the dots. I've always said you go to a cardiologist, you get treated for angina, you go to a psychiatrist, you get treated for depression. But suddenly, if a woman says, Doc, could it be my perimenopause or menopause? And the doctor suddenly thinks, "Yeah, actually, it could." So she's got to start doing her own. You have to do your background. You have to go prepared. Go with a list of questions and be very inquisitive and inquiring. Um, Science has a lot to offer you, but it's for you to ask for it and get it.
Be as protective about your health as you are about your family.
Absolutely. Absolutely. I mean, if you want to do all the stuff you want to do, you better look after yourself first.
Yeah, I wish women would mama bear themselves as much as they do everyone else. Which is that really furious, angry, you will not touch my child sort of reaction that comes should also happen about your own health. Well, one of the things that I love is I use the gym in the building that I'm in, and there are regularly now women in their 70s and their 60s and their 50s, lifting weights, and, they're on the treadmill and they're really actively taking care of themselves, which is such a heartening thing to see.
Wonderful, wonderful. And again, women have in a way just arrived on stage. And I always say that 10 years ago, almost no pharmaceutical company had a women's healthcare division. And now all of them do. So suddenly they've noticed, and they'll only notice something if it matters to them commercially. And suddenly women have arrived. And they all want to set up divisions, and they all want to give us preparations and more preparations for women. So that I'm really, really glad about.
Is it true in terms of women's health that until very recently there was no research independently done to study what happens to women's bodies, under various situations from the medical fraternity?
We're still lagging behind.
Okay.
More is being done. And, in a lot of ways, so I'll tell you something very interesting about Hinduja also. They decided to have 4 centers of excellence and orthopedic, neurology. And that's when we came up with what about mother and child?
Hmm.
And we actually agreed to have a 5th center of excellence on mother and child. So I consider that's a message of how important what we do is. For mother and child, we don't need great research. We need great care. We need empathy. We need to give her the best experience in the world. So that's where things have changed. Research has started happening, but the kind of research you had on issues of male health and disease never happened for women. In fact, I saw another very, very not happy statistic which said that when you look at all the venture capital in health, barely 2% or 3% goes into women's health issues. So that has to change.
Yeah.
And I think it will change because, like you rightly said, those women are there in the gym. They're looking after
I mean,
themselves.
they're there. I mean, women are in the VC companies.
And so it's high time they started putting their
You're
money where the,
dispensing the money
where the
where-
seat is, because it is going to be something that's going to be really, really important in future. I mean, just have to see what's happened to social media and some of the amazing people who put out stuff on social media. Not all of it is great, of course, but a lot of good stuff. And what I've seen in the last 5 years when it comes to women, particularly perimenopause, has been just like
I mean, I'm going to stop now because if I don't, we'd go on until next week. So. Yes, I have so many questions, but I'm so grateful to you for patiently answering all of our questions. And for our viewers who are watching this, if you have a question, put it in the comment section and we'll try and convince the doctor to come back and answer more. Thank you.
Thank you, Faye.